Hi everyone, very good evening to everybody. Good evening. Are you all able to see me and hear me? Yes? Right, yes, it's just maddening, the COVID thing, and situation is really tense here. I hope everybody there is fine, you and your family. Yes? Okay. The practical aspect, and as decided, our aim was to increase the coverage even further, right? And we have selected topics which, either you find difficult or we know will be asked in some form or the other in your exams. It could be theory, it could be practicals. So we would be covering the topics that we have mentioned in the course for practical, and it's a pleasure to get connected to all of you once again, right? And as I said, today we will be starting with instrumental delivery, right? And then I think the next topic that you all want to do is contraception. So we would start with contraception after instrumental in the next class. Now the plan for this session on practical is that it's going to be a shorter session. So we want to finish it up in around 12 days or so, maximum maybe 15, by keeping alternate sessions. So that is what we are planning, that we would keep alternate day sessions. Is that okay with everyone? Yes. So we would keep alternate day sessions. We would start at 5 p.m. in the evening, and these would be around 2 to 3 hour sessions, okay, where we will try and cover things that we should know for the exams, right? And as I said, today we will start with instrumental delivery, right? So the instrumental delivery that you all could be forceps or could be vacuum. So we would see both the practical and theory aspects of instrumental delivery. I'll show you various things which I know you people may not be knowing because of either lack of exposure, because forceps is something which is not seen very frequently in the hospitals now, and not everybody is well trained for forceps delivery. So we'll try and cover those aspects here, right? Now when we talk about instrumental delivery, what are going to be the indications to use? And in fact, what I would like is that in the practical classes, maybe you can come and read and come as well. So it'll doubly help. You can ask your queries, you can read that part by yourself and come, and then it would be even more interactive and you will learn even more, and I'll get a chance to ask questions from all of you, being at a position where we have taken exams for many years. That is something I actually miss in the private sector. So I haven't taken exams now, which I used to be a part of in Lady Hardinge every year, right? So from DNB exams to MS exams, right? And that's something you actually miss in a corporate setup. Okay, so let's talk about indications for instrumental delivery, right? So the first indication for instrumental delivery is, it is going to be maternal exhaustion. Right, so maternal exhaustion, where the woman is no longer able to bear down, is one of an important indications for instrumental delivery, right? The second indication for instrumental delivery is maternal medical conditions. Right, so maternal medical conditions like cardiac disease, okay, where you don't want the woman to bear down, right? So in the cardiac disease, you don't want the woman to bear down, because if she does, this is going to increase the load on the heart and can lead to congestive heart failure, right? The third important indication, very good amigo, right, is, as amigo said, prolonged second stage. Now, I'm not sure how many of you know the correct definition. So do you know the correct definition of prolonged second stage? Or in other words, if we talk about arrest, right, of second stage, do you know the correct definition? So before you apply instrumental delivery, it should be 3 hours of pushing, okay, in a primigravida, and 2 hours of pushing in multigravidas, right? So 3 hours of pushing in primigravidas, 2 hours of pushing in the multigravida, and these cutoffs are in the absence of epidural, right? So in the absence of epidural analgesia, the cutoff that we use is 3 hours and 2 hours. In case the woman has epidural in place, right, then the cutoffs are going to increase by 1 hour. So it is going to be then 4 hours in primi and 3 hours in multi. Right, now please understand one thing, there is no doubt that to call it as prolonged or arrest of the second stage, you know, we are saying that you should wait for 3 hours and 2 hours or 4 hours and 3 hours, right? The most important thing that you have to know here is, when we say you wait for this long, this is only valid if the FHR is normal, right? So we are not going to wait for 3 hours if there is fetal distress, or 2 hours if there is evidence of fetal distress. So this waiting is valid only as long as the fetal heart rate is normal. Is this clear? Yes. Then the fourth indication for instrumental delivery is what? When there is immediate or potential fetal compromise, right? So I'm sure we all know that in fetal distress, we've always talked of cesarean sections, but you should know that when there is fetal distress, you can do instrumental delivery as well, obviously, provided the criteria for instrumental delivery are met, right? So if the criteria for instrumental delivery are met and there is potential fetal compromise, or there is an already existing fetal compromise, which I mean is fetal distress, you can do instrumental delivery. Yes, is this clear to everyone? Okay. Now, once we know this, the other important things that we should know is contraindications, right? So, because, you know, this is the first thing that you should know when we talk about an instrument. When can you use it and when should you not use it, right? So what are the important contraindications? Can anyone help me on that? What are the important contraindications? So the first one is extreme fetal prematurity, right? Which we generally say less than 34 weeks, right? So if there is extreme fetal prematurity, you should prefer doing a cesarean section rather than going in for instrumental deliveries, okay? The second important contraindication is a fetal demineralizing disease, right? So a fetal demineralizing disease like osteogenesis imperfecta, right? What would this do? This would cause intracranial hemorrhage as well as brain injuries. Right? The third important contraindication is fetal bleeding disorders. So we are not going to use it if we know that there are bleeding disorders. The fourth one is if there is a suspected fetal pelvic disproportion, right? So if there is a suspected fetal pelvic disproportion, there is no way that you should try instrumental delivery, right? Very good. As Nikunj has written, so yes, cephalopelvic disproportion would be an absolute contraindication for application of instruments. Then, so amigo, we don't put them as contraindications. जो आप कह रहे हो बेटा, they are requirements. They are not contraindications. Okay, so when you specially say contraindications, these are the things that you should mention in the exam, whether it is asked as a viva question or if it's asked as a theory question, right? I will tell you what prerequisites are and when you should answer those things, okay? And also, you know, typically brow presentations as well as mento-posterior presentation. Right? So brow and mento-posterior, again, we are not going to do any instrumental deliveries. Right? So these are the important contraindications that you should mention when they are asked in the exam. So fetal extreme prematurity, a fetal demineralizing disease, fetal bleeding disorders, suspected disproportion, or a brow and mento-posterior position. Yes? Now the third thing, once you know where to apply and once you know where not to apply, the next thing is, suppose ये तो decide हो गया कि forceps लगाना है या vacuum लगाना है. The next thing we need to know is, are the prerequisites met, right? So what are the prerequisites for instrumental delivery, right? So this is where, amigo, we are going to comment on the things that you have said. So the first important thing is that cervix should be fully dilated, right? Now please remember, cervix should be fully dilated is an absolute requirement, right, for forceps. So for forceps application, this is a absolute requirement, and this is the preferred requirement for vacuum. Now what do I mean by that? Sometimes, if required, vacuum device can be applied beyond 6 centimeters of dilatation. So zarurat padne pe the vacuum can be applied, but ideally even for vacuum it should be a fully dilated cervix. Okay. The second important requirement is ruptured membranes, right? So you all know that membranes are slippery, and if they are intact, they will not allow correct application and grip on the fetal presentation, right? So membranes have to be ruptured. Yes, Sana, we will talk about it. Okay, so membranes have to be ruptured. Okay, then the next important thing is that there should be no obstruction in the path. Right? What do we mean by this? Example becomes a big fibroid uterus or a big ovarian mass in the pelvis. Right? So a fibroid filling up the pelvis or an ovarian mass filling up the pelvis. So we don't want any obstruction for in the passageway, right? If we are to apply instruments. So Nikunj, you don't call them as indications. The indications are what we have mentioned, right? The indications are delay, or indications are maternal exhaustion, right? So when you are saying for after coming head, if you say it like this, it means it is mandatory to apply a forceps. Is it mandatory, Nikunj, to apply a forceps in after coming head of breech? No. You could deliver the breech by Burns-Marshall, you could deliver the breech by MSV. So it's not an indication, yes, but it is one of the options that is available to you. Okay, so you don't put it as indications. Okay. We will talk about what you people are talking about. You people are talking about what all you should check for. So we will talk about it. Okay. So no obstruction in the path. That's an important prerequisite. Okay. Then there should be good uterine contractions. right? So whatever pulling we are going to do are going to be synchronous to the uterine contraction, and there should be good uterine contractions when you are applying forceps or vacuum. Then empty bladder and at least a engaged head, right? So bladder should be empty, okay, to facilitate the delivery, because otherwise the full bladder is going to occupy the space, right? So empty bladder, the head has to be engaged. Now we will talk about details of this, which means at stations above 0, we are no longer doing any kind of instrumental delivery. So the minimum requirement has to be a station 0, right? So the head has to be engaged, which means the biparietal diameter should have crossed the pelvic brim, right? So BPD should have crossed the pelvic brim, right? Then P is what you were talking about. I put them as favorable presentations. So which are the presentations, right? Which are the presentations where you can apply instruments? So obviously one of the favorable presentation is going to be vertex, right? You can apply it in OA, you can apply it in OP, yes? Then after coming head of breech. So yes, you can apply if you are talking about delivery of after coming head of the breech, and you can apply forceps in mento-anterior position. Okay, so you can apply forceps in face, but typically what face? If it is mento-anterior. Please remember, I have taught you that as far as mento-posterior is concerned, there is no mechanism of labor, right? So you will apply forceps only and only if you're talking about mento-anterior, okay? Otherwise you will not apply the forceps. Now please remember, when we talk about prerequisites, the next very important prerequisite is what? It is adequate pelvis, or I would say on clinical pelvimetry. So that's what we do, right? So on clinical pelvimetry, it should be adequate pelvis. For example, what I would want you to know here is that if you come across a flat sacrum, right? So the sacrum is flat, not hollow, the curve, right? Or if you come across a narrow subpubic arch, right? So flat sacrum, a narrow subpubic angle, narrow interischial spine distance, yes? Then these are what? Favorable or unfavorable? So when you do a clinical pelvimetry, you have to typically look at this. So these things have to be absent, right? So if it is present, they are unfavorable for instrumental delivery. So when you do a clinical pelvimetry, please watch out for the curve of sacrum, watch out for the subpubic angle, watch out for the interischial spine diameter. What else? Can you again tell me what else would be a prerequisite? So another important prerequisite is that there should be facility available for what? Immediate cesarean section, right? So there should be facility available for immediate cesarean section, yes? So if that is not there, then this is not a suitable place where you should be doing an instrumental delivery. Now, although these are absolute requirements, please remember, if your patient has certain other features, then they are not ideal candidates. For example, what I would say is if your patient has severe obesity, right? Typically we say BMI more than 40, right? So if your patient has severe obesity, or if the baby's weight, right, which is obviously going to be the estimated birth weight, is either more than 4 kg, yes, or less than 2 kg, right? Then again, these are not ideal candidates, right? So they are not, so weight हम कोई absolute requirement नहीं बोलते हैं, but definitely yes, if the weight is towards the extreme parameters, which is more than 4 kg or less than 2 kg, yes, then we say these are not ideal candidates for instrumental delivery. So apart from prerequisites, look out for maternal obesity and also look out for estimated birth weight of the baby. Yes, and something which is very important that Poonam has mentioned, and she is right, whether you do an instrumental delivery or not is going to be dependent on patient's consent. So one of the important prerequisites is patient's consent, right? And especially अगर हम कहीं बाहर practice कर रहे होते, we are in India, so in India we don't really give a lot of, so in India we don't do a lot of consensual things, right? And often we would take decisions, but please remember, patient's consent is an important requirement, right, when it comes to instrumental delivery. Is that clear to everyone? Yes? Okay. Now, once we know this, what are the next things that we should know? Okay. Obviously, we are going to talk about forceps and vacuum, right? But what we need to know here is, just give me a moment, please. I have to manage some patients also side by side. Just a minute. Right. So, anesthesia is also an important requirement when we talk about prerequisites. So for example, what anesthesia do you think would be required for forceps? So ideally for forceps, it should be neuraxial anesthesia. Right, so what does neuraxial include? So neuraxial includes your epidural, your spinal, right, or combined spinal epidural. So अगर already patient को epidural catheter लगा हुआ है, it will take care of the requirement for forceps as well. अगर नहीं है, then this is what is ideal for forceps. Otherwise, what you can do for both forceps and vacuum is pudendal nerve block. Right, so otherwise what you can also do is pudendal nerve block. A lot of times in government hospitals, vacuums are actually given even without a pudendal nerve block. I'm sure you have seen it like that. So yes, it can be done that way as well, but then it is going to cause pain to the patient, right? So those are not ideal things that you might have seen in your hospitals, right? So please remember, forceps के लिए ideal is neuraxial anesthesia, मगर हम pudendal nerve block से काम चला सकते हैं. For vacuum, it should be at least a pudendal nerve block, but yes, we can manage even without any kind of anesthesia as far as vacuum is concerned. That's one of the advantages of vacuum. Okay. Then the third important thing is, what about antibiotics? Do you need to give antibiotic prophylaxis to every patient? So this is what you need to know. There is no need of routine antibiotic prophylaxis, right? So there is no need of routine antibiotic prophylaxis. Okay. A very important thing which I would want to ask you, what about episiotomy? What about episiotomy? So again, please remember, episiotomy is not routinely recommended. So as far as international guidelines go, okay, it is not routinely recommended. Majority of times for vacuum, we may not be giving an episiotomy. But yes, if we talk about all government hospitals, we have been giving episiotomies for forceps, but it is not a routine thing, right? So it's not routinely recommended. If the clinician feels she needs to give an episiotomy, then yes. So we have talked about this before. If she needs episiotomy, right, which one are you going to give? You're always going to prefer a mediolateral, especially with instrumental delivery. So we have seen if you give a midline or a median episiotomy and if you do instrumental delivery, there is even higher chance that you are going to go into the anal sphincter, right? So for those reasons, if at all you're going to give an episiotomy, it should be mediolateral episiotomy. Yes, is it clear to everyone? Now comes the next important thing. Now once we have looked for all these things, once we are going to apply an instrument, what is the next decision that you need to make? So अभी तक हमने इंस्ट्रूमेंट लगाने से पहले क्या क्या देखना है वो बात करी, राइट? कि इंडिकेटेड है कि नहीं है, कहीं कॉन्ट्रा इंडिकेटेड तो नहीं है, इफ इट इज इंडिकेटेड व्हाट आर द नेक्स्ट चेकलिस्ट दैट आई शुड सी, राइट? Now once I have seen the checklist and my requirements, and now when I want to put an instrument, the next thing I as a clinician have to decide whether I'm going to put forceps or I'm going to put vacuum. Yes? So how do you decide whether you put forceps or vacuum? ये कैसे decide करें? Yes? So how do you decide whether you put forceps or whether you put vacuum? Now the first important thing is the expertise of the clinician. बाकी सब actually बाद में आता है. So majority of times when you are in your labor wards, you would see most of the people doing vacuum extractions, right? Very few, especially, I don't know, I think with Mumbai at some places, they are still doing instrumental delivery, but when you talk about Delhi, I think we are hardly doing any instrumental deliveries. Okay, so the most important thing is clinician's expertise. Okay, because forceps needs training. That's one of the most important thing, right? So if you're not trained, then you obviously have to use vacuum. You don't have an option, right? So in general, vacuum is more easier to apply and usually does not need a training process, but forceps definitely needs training. The second important thing is when you think that it is going to be an easy extraction, okay, if you think that this is going to be an easy extraction, then you will prefer vacuum. Yes, so please remember, when easy extraction is anticipated, right, then we definitely prefer vacuum. Okay, but once you feel that it is going to be a difficult extraction, then it should be forceps. Okay, so then it should be forceps. Also, I told you, if you do not have facilities for anesthesia, that's again going to help you decide. So if you really don't have any facility to give epidural or a pudendal nerve block, right, you just want to do it under LA, then probably we are going to go in for vacuum, because I told you that one of the advantages of vacuum is that it will not need, as I said, you will not need a anesthesia for it, right? Then obviously the other deciding factors are the presentations. As I said, that if it is after coming head of breech, okay, or if it is mento anterior, then as I said, you cannot use vacuum in these two conditions. Okay, here it has to be a forceps, right? So here it has to be a forceps. It cannot be a vacuum. Yes? Okay. Now, then the next important thing that you need to know is, when we talk about this, is the other things where we are deciding are not absolute. For example, what about women with heart disease? What about women with heart disease? Now see, the sole idea of using an instrument in heart disease is that you have to cut short the second stage, right? You don't want the mother to bear down, right? Because if you allow her to do that, then there are certain heart diseases where it would lead to cardiac decompensation. So if your patient is a case of heart disease and you don't want her to bear down at all, then which one would you prefer? So practically, yes, in heart diseases, you can apply vacuum and you can apply forceps both. Both instrumental deliveries can be done. But when you don't want maternal pushing at all, right? So when you don't want maternal pushing, then obviously it has to be forceps over vacuum, right? So when you don't want the mother to push, then it has to be forceps over vacuum. Yes, is this clear to everyone? Okay. So please remember this, okay, that actually practically both can be used, a vacuum device as well as forceps device. But if she has a certain cardiac condition where you do not want any kind of bearing down efforts, then it has to be forceps over vacuum. Then when we talk about, such conditions, what about HIV? Yes. So here again, what do I want to say is, generally when we talk about guidelines about HIV, we say avoid instrumental delivery. Right, so we say avoid instrumental delivery. But if at all you want to really use an instrument, then which one are you going to prefer in an HIV positive patient? What is the answer there? What is the answer? So guidelines are avoid instrumental delivery in HIV positive women. But I'm saying if we do want to give or use an instrument, then which one are we going to use? So here again there are lots of debates. Yes, the earlier guidelines were don't use it, but now the new guidelines say that instrumental delivery can be done. Okay, if required, it can be done. So it's not a contraindication, but yes, you should avoid it. Right? So in which case, which one do we prefer? So I always see majority of students answering vacuum, but it is actually forceps over vacuum again. So if at all you want to use an instrument in HIV positive, it should be again forceps over vacuum. Why? Can you think about the reason why? Anyone? So the reason is, no. So it's not vacuum, it is actually forceps. And what is the reason is what I'm trying to ask you. So please remember, forceps are less likely to damage the integrity of fetal skin. Okay? So when you talk about scalp lacerations and those things, yes, they're more common with vacuums. So less likely to damage the integrity of skin. अच्छा, जहाँ पे ये जो बच्चे वैक्यूम लिख रहे हैं, आपने कहीं ऐसा गाइडलाइन पढ़ा है या आपको ऐसा लगता है? So is it you who feels it should be vacuum, or have you seen it as a guideline? Because I know there are a lot of controversies on this. Different places say different things, but yes, this is what we generally go through when we go through various articles or various journals or guidelines which are international guidelines. We don't have any national guidelines. Our national guidelines simply say avoid instrumental delivery. Our national guidelines do not really say which one to be done if at all you have to do something, right? So these are the things which will help you decide. Other than that, I have told you that if the fetal head or if cervix is beyond 6 centimeters and you want to use an instrument, then it should be which one? Then it should be vacuum. But as I said, for vacuum also, the ideal is full dilatation. If the baby is preterm, yes, if the baby is preterm and you want to use an instrument, then again, here it should be forceps. It actually protects the baby's head, right? So these are some of the other things which you should know. Fetal distress. So nowadays, you know, earlier we used to say the same. Okay, so earlier we used to say that if there is fetal distress, forceps should be preferred over vacuum. क्यों बोलते थे ऐसा? ये पुराना guideline है. So ऐसा इसलिए बोलते थे because as per the older guidelines, we used to teach as well as practice that in vacuum you should slowly raise the pressure. Okay, so the pressure has to be gradually raised. But as per the new guidelines, this is no longer true. With better cups available, we are doing a rapid increase in pressure. So these were actually old guidelines when more of metallic cups were used, and at that time they used to say that you should gradually raise the pressure, and if you will gradually raise pressure, you will take more time. So अभी भी अगर आप किताबों के बारे में पढ़ोगे, so किताबों में हो सकता है ऐसा लिखा हो, but the newer guidelines actually say that even vacuum can be used in fetal distress because now you can do a rapid increase in pressure with vacuum as well. Okay, is this clear? Right. Now once we know this part, which instrument to use, let us now try and learn something about the instruments as well. I'm going to ask you a few things. You can ask me back. We can have an interactive class and let's try and learn, because I feel that forceps और vacuum में बहुत बार बच्चों को basics नहीं आते होते, right? So that is entirely my goal, that we have to know what you're going to be asked in the exam, huh? Okay. So we would do some very basic things because I really feel that a lot of students do not know the very basics as well, है ना? So इसीलिए once we are facing these questions, we should know what to answer. Okay. Now the first thing I want you to know is, let's look at these slides and let's try and learn some basics and then we will move forward. So when you talk about forceps, these are the parts that you need to know. Okay, and I have got the forceps with me as well. So, but what I will do is I will try and first show you with the presentation because बहुत basics में problem नहीं होना चाहिए. Then we will try and see it on the real forceps as well with a black background where you can see it proper. Right. So, as I said, you know, this is the handle. That's where you're going to hold the handle, right? So where you hold the forceps is called as the handle, right? So that is the first part I want you to know. Now generally different forceps will have different dimensions, but generally if we have to answer, we are going to answer it as 12.5 centimeters. Okay, so the handle is 12.5 centimeters. Okay. Do you know that the handle has a finger guard, right? So you can hold it properly. We will talk about that as well. Then, as you see in the middle, between the blade and the handle is the shank. Yes. So between the handle and the blade is the shank. Now shank is what is going to give length to the forceps, right? So if you have to make it longer, the shank will be longer. If you have to make it shorter, the shank will be shorter, right? So it is actually the shank which will decide the total length of the forceps, right? So again, it could be variable, but generally if we have to answer, we'll answer it as 6.25 centimeters, okay? Then there are blades. So as you can see, these are the blades of the forceps, okay? Now, the very basic thing that I want you to know is that there are two types of blade. Do you know two types of blade? So here I have showed you only one type. I will gradually show you the other type as well. Yes, but when I talk about two types of blades, what are you going to tell me? So one is a kind of blade which has fenestration. Fenestration का मतलब समझते हो? Right? So fenestration, look at this. If you look at this forceps, are you able to look? So ये जगह है blade में. This space in the blade is what is the fenestration, right? So this is the fenestration. So it's a fenestrated blade. Another one would be solid blade. So I will show you what I want to tell you as a difference between the two. Yes. So let's look at this. What kind of blade is this? Solid or fenestrated? So इसमें कोई जगह नहीं है. This is actually a solid blade. Yes, can you all appreciate that it is a solid blade? Whereas compare this with this one. Forget about the names right now. Just let's do the basics, right? So whereas look at this one. This has space in the blade. So this is a fenestrated blade. So when there is space, we call it as fenestrated. Otherwise it's a solid blade. So the first thing that I would really want to know my postgraduates to know if I'm taking your Viva, why or what is the advantage of a fenestrated blade? Can you tell me? What is the advantage of a fenestrated blade? So please remember that when you talk about fenestrated blades, they actually give better grip. Okay, they give better grip. They are therefore less likely to slip. Right? So they are less likely to slip. Yes? But what is the disadvantage? So they give you a better grip, they're less likely to slip. But what is the disadvantage? The disadvantage is that they can increase risk of tissue laceration. Right? So they can increase risk of tissue laceration. क्योंकि उसके अंदर tissue भी फंस सकता है ना? So it can increase the risk of tissue laceration. Yes, is this clear to everyone? Okay. Now, let's go back to the very basics. So where the blade meets the shank is what is called as the heel. Okay, so what is the heel? Where the blade meets the shank is what is called as the heel. So are we all clear about handle, shank and blade? Yes? Are we all clear about these things? Handle, shank and blade? Yes? Okay. Now comes the second most important thing, which I feel most students probably don't understand. As you can see, the blade will have two curves. Yes, so these are the parts that we have already done. So we have talked about the blade, we've talked about the shank, we've talked about the handle. So we are going to talk more about the blade and then I'll come to the lock as well gradually. Okay, so I have told you what is heel. Heel is where the blade meets the shank. What is the toe? As you can see, the tip is going to be the toe. So if you can you all see the instrument in my hand? So this is going to be the tip, right? Or toe, to be very precise. So toe and heel. Okay, is it clear what is toe and what is heel? Now coming to the curves. So the blade is going to have two curves. There is going to be a cephalic curve and there is going to be a pelvic curve. Cephalic curve kaun sa hai? So look at the instrument in my hand. The surface of the blade, which is going to be in contact with the head of the baby, right, is called as the cephalic curve. Is it all clear to everyone? Yes? So this part of the blade, जो बच्चे के head पे लगने वाला है, and I'm going to bring the head, the fetal head as well. I forgot to get it. I'll get it in the break. Okay. So this part, which is going to be in approximation with the head of the baby, is the cephalic curve. Is the cephalic curve clear? But what is the pelvic curve? Now please understand this. I'll give you the details of the cephalic curve in a moment, but first understand the difference between the two curves. What is the pelvic curve? Now look at the instrument in my hand again. Can you all see the instrument, or you want me to zoom it a little? But I start looking horrible when I zoom it. So let's see. Okay, I am sure you're able to see the instrument better now. Yes? Okay, so I said the inner surface which is going to come in contact with the baby's head is what is the cephalic curve. But what is the pelvic curve? Now look where my hand is. This part which is convex and this part which is concave is what is the pelvic curve. Yes, so I'm going to move my hand again. The cephalic curve is what is inside, which is going to come in contact with the baby's head. Pelvic curve kaun sa hai? Ye niche wala, that's along the bottom, and ye upar wala. This is what is the pelvic curve. Is this clear to everyone? Yes? So बहुत बच्चे क्या करते हैं, बोलते हैं अंदर वाला cephalic curve है और ये, and they will say ये बाहर वाला pelvic curve है. नहीं भाई, ऐसा नहीं है. Alright, so yes, the inside is the cephalic curve, but the top and the bottom is what is the pelvic curve, right? So I don't want any confusion on this. Yes, is it clear to everyone? What is cephalic curve and what is pelvic curve? Okay. The next thing that I want you to know is, thank you Ranjana, that's really kind of you, but I think that doesn't matter, right? One should, but anyway, thank you. Okay, let's go ahead. So when we talk about cephalic curve, I don't think they will ask you details about the radius of curvature or other things, but still, in case they do, this is what I want you to know. So when it comes to cephalic curve, okay, the radius of curvature is around 11.25 centimeters. Okay, so the radius of curvature is around 11.25 centimeters. Now, do you see that there is a distance between the toes? Yes? Do you see that there is a distance between the toes? Yes? So, you know, this distance between the toes is going to be around 2.5 centimeters. Okay? So this is going to be 2.5 centimeters. Now comes the question that they might ask you in the vivas. Why? Why are they not touching each other? Why is there some gap between the toes? What would you answer? What would you answer? So, you know, this ensures that excess compression of the head is not done. Right? अगर ये बहुत close होंगे, इसका मतलब वो बहुत tight होगा. Right? So if at all they ask you that why should there be a distance between the toes, the reason is to avoid what? Excessive compression of the fetal head. Is this clear? So please keep writing the Q&As. So why is there a gap? To reduce the compression on the fetal head. Is this clear to everyone? Okay. Then what is the maximum distance between the, you know, cephalic curve of the two blades? What is the maximum distance? So if you, once you articulate them, and I will teach you how to do that, what is this maximum distance? The maximum distance is around 9 centimeters. this is where the biparietal diameter will come, right? So this is 9 centimeters, right? That's where the biparietal diameter will come. So biparietal is 9.5. So this is not very, it's not loose at all, but it's not very tight. Yes, so it will give just the right amount of pressure that is needed to grasp the head, but not excessive pressure. So if you make it more narrow, the pressure will increase on the baby's head. Is it clear? So this is to ensure adequate grip. So if they ask you why should it be, why is it 9, why is it not 8, why is it not 9.5, right? So this is to ensure adequate grip. Right? Is this part clear to everyone? Okay. So those are the things that you should know about the cephalic curve. Now coming to the pelvic curve. As I said, pelvic curve will have what, bache? It will have one concave part and one convex part. Right? So one concave part and one convex part. So concave and convex. Okay? Now, if we ask you this pelvic curve is going to go along what part? So remember, the curve that is there on the pelvic part is going to fit the curve of sacrum or the curve of Caris, right? So this pelvic curve that we have given is to fit the curve of Caris, which is the, you know, the obstetrical outlet, right? So the baby is going to follow the the anatomical outlet. So the baby is going to follow the anatomical pelvic axis, right, which is what is called as the curve of Caris, right? Okay. Please remember, very important thing about the cephalic and the convex, the concavity and the convex part. When you are holding the instrument, so I have to teach you very, very basic things as well. So please listen to me very carefully. I will again zoom and show so that you understand what I am trying to tell you. Okay. Let me, I have a black background as well. So just a moment, let me see where. Yes, so I think this will help you see better, right, the black background. Right, so let's look at this. So as I said, there is a concave part and there is a convex part of the pelvic curve. Yes, you can all see that. Now when you are holding the instrument, okay, so look at this. So when you are holding the instrument, the concave part should be anterior, the convex part should be posterior. Yes, is it clear to everyone? So when you hold it in the correct position, yes, so when you hold it in the correct position, the concave part should be anterior, the convex part has to be posterior. Is it clear? Yes, so समझने की बात है that this convexity has to be posterior because it is going to fit in the curve of or in the concavity of the sacrum. Yes, is it clear? Yes, is it clear to everyone? Okay, so please remember this. This convexity has to be posterior because it will fit the concavity of the sacrum. Yes, is it clear everyone? Okay, I'll zoom out now. And I will go back. Right? Now, what is the radius of pelvic curve? So, although I really am not going to ask you radius, and believe me, even your examiners won't ask you the radius, they will ask you more important things. But just to give you a feeling of completion, right, the radius is 17.5 centimeters as far as the pelvic curve is concerned. Yes, is it clear? Okay. Now, as I said, the third part we have to talk about is the lock. Okay. So, first we will talk about two types of locks here. There is a English lock and there is a sliding lock, right? First the images, then Priyanka, the concavity and convexity are on the blade itself. The convexity of the blade has to fit the concavity of the sacrum. Okay? So listen to me very carefully. Agar ye sacrum hai मान लो, right? So this is, let's say, the concavity of sacrum. इसमें क्या fit होगा? Convexity of the blade. Can you see this? I can't fit the concavity of the blade. तो ऐसा हो जाएगा. Right? So convexity has to be in the sacrum. Is it clear? So आपको ये याद रखना है प्रियंका, that concavity has to be of the blade, has to be anterior and convexity has to be posterior, because convexity has to go into the hollow of sacrum. Yes? Priyanka, is this clear, bache? Okay. Now we have to look at the lock. So for which I will again go to the real instrument and then I will come back. Okay, let me zoom myself out first and then I will bring the instrument. Okay, can you see the socket? Yes, can you all see the socket? Yes, in one of the blades, right? So just at the end of the handle, can you see the socket here, everyone? First you will tell me that you are able to see the socket. Yes? A similar socket is present in the other blade as well. So both the blades are going to have the socket. Yes? So both the blades are going to have the socket. Okay? Now, we have to know that these sockets are going to go into each other. So I am articulating it for you, right, like this. Now can you see the sockets with each other? This is the kind of lock which is called as English lock, right? So this is what is called as the English lock, where both the handles have sockets. I will teach you how to do the articulation, but could you see? I am showing it again, right? So I am showing it again. The sockets are going to fit into each other, right? Just a moment. Yes. So the sockets are going to fit into each other and this is what is called as English lock. Is this clear to everyone? Yes? Okay. Then the other kind of a lock is where you can, okay, so the other kind of lock is where you can move it up and down, the shank. Yes, so if you can move it up and down the shank, that is called as sliding lock, right? So most of the forceps that we are using will have an English lock, right? So they will have a English lock. Those are the two important things that you should know when it comes to this. Now please remember one more thing that I want you to know, which is when we talk about a short shank, fenestrated blades, what other advantage do they have? Right? A short shank, fenestrated blade. What is the other? Yes, I will talk about that. Panchami, I know what are your pain points. I will tell you how to pick up left and right. Okay? Yes. So now, once this is clear, what was I talking about? So I was talking about, if we know this, right? So most of the times the instruments that we are using are going to have a English lock, right? So we are going to have an English lock. Now there are different names. I will tell you certain names, but what we use is mostly a Wrigley's forceps. So the one that I am showing you is what would be in your vivas, and that's a Wrigley's forceps. Remember, it has short shank. Do you see this, or do you want me to show it to you on the black background? Right. So let's look at this. Let me zoom it in again. Yes. So this is the Wrigley's forceps. Okay. So if you see, the Wrigley's forceps has a very short shank. Yes. It has a very short shank and the blades are fenestrated. Can you appreciate? Yes. The blades are fenestrated and it has a short shank. So one reason I told you why the blades are fenestrated are because they will, help in better grip. Yes. But what is the other advantage of a short shank and fenestrated blades? They make the instrument more light. Okay. So they will make the instrument more light. Is this clear? Whereas if there is a long shank or, if the blades are solid, they will make what? They will make the instrument more heavy as well. So the Wrigley's forceps that we are using is actually a light and a small forceps. Okay, it's a light and a small forceps. Yes, is this clear? Okay, now comes the correct identification, right? So this is what I have just shown you. So these were the hooks that I was talking about, right? So this is the English lock that I was talking about. And as I said, this is the one that we use most commonly. This is the one I'm showing you as well. So it has short shank and it has fenestrated blade. This makes the instrument more light as well. Okay. Now coming to different names, and then I will tell you, which or how to identify left and right and how to apply it as well. Okay. So these are the different types of forceps that you should know. Okay. So इंडिया में हम ज़्यादातर Wrigley's यूज करते हैं, but abroad they are using Simpson's or they are using Elliott and Tucker McLean. So this is a Simpson forceps. It has an English lock. What you need to know about Simpson is that this has a long blade. I think you can very much appreciate that. कितना लंबा blade है. So it has a long blade and it is used for molded head, which you are more likely to see in Primigravida, right? So head undergoes molding. So these long blades are especially useful where the head is molded, like in Primigravida. Okay. Then there are two other names that I want you to know. So one is Elliott and the other is Tucker McLean. Right? So Elliott and Tucker McLean, they are used for round or unmolded head. Right? So for a round or an unmolded head, which means they would be used in multigravidas. Is this clear to everyone? Yes? So in multigravidas, it will be Elliott or Tucker McLean, right? And in Primigravida, it is going to be Simpson. But this is what they use abroad. Okay. What do we use? I told you in India we are using what? We are using Wrigley's, which is the one I showed you before. Now please remember all these four. Okay? Whether it is Elliott or it is Tucker McLean or it is Simpson or it is Wrigley's, they are all outlet forceps. Okay, so these four, right? Elliott, Tucker McLean, Simpson and Wrigley's, they are all outlet forceps. What are outlet forceps? We will talk about this. Also remember that the outlet forceps can be used as low forceps as well. So we will talk about this classification in a moment. But yes, these are outlet forceps. They could be used as low forceps as well. Okay. Then you have to remember that the forceps which has a sliding lock is called as Keyland forceps. Right. So Keyland is to be typically identified by its sliding lock. Is it clear to everyone? Yes. And it is a rotational forceps, which means when you have to try and rotate the head of the baby, let's say from transverse position to anterior position, then you can't use Wrigley's or outlet forceps. Okay, so then if you want to rotate the head from transverse to anterior positions, you will have to use a Keyland forceps, and the only way or the best way to identify Keyland is that it has a sliding lock. Yes. Pipers, okay, let's look at Pipers, right? So Piper is actually, let me see if I have a little better picture for Pipers in a moment. Yes, so let's look at this. So this is what I was talking about. So this is actually the sliding lock of Keyland forceps, and that's how you really identify it. Okay. Tucker McLean, I have already showed it to you. So it's a solid one, but I told you this is used for rounded heads. The blade is not very long. Yes, the blade is not very long. Then Pipers, right? Now when it comes to Pipers, it is again a very long forceps. But the most important thing about the Piper is that it does not have a pelvic curve. Okay, it does not have a pelvic curve. What curve does Piper forceps have? Piper forceps actually has a reverse pelvic curve. Can you see this? Right, so we say it has a reverse pelvic curve, or we say it has a perineal curve. Okay, so this curve that the Piper has is actually called as perineal curve. Okay, और इसके blade आपने देखा है कितना लंबा है, and the body of the baby is going to rest on it, right? So it actually has a perineal curve or a reverse pelvic curve. It is a very specific use, which is after coming head of breech. Yes, so this is used for after coming head of breech, right? Now coming to how are you going to identify what is left and right, because before you do anything else, you must know how to identify left and right so that you are able to apply it. Yes, are you ready for that now? Okay. So what is the most important thing? They are going to give you the instruments disarticulated, right? So they're going to be on the table, viva, and it's going to be disarticulated. So you have to pick up both if they are giving you both, or maybe the examiner picks up one and gives you one, right? So, or they say pick up the instrument. So you pick up both, okay? And it's called as a pair of forceps, right? So it's plural, it's a pair of forceps, right? Now, how will we identify left and right? सबसे पहली चीज ऐसा लग रहा है मैं कड़छी लेके कहीं लड़ाई पे जा रही हूँ. Okay, so the first thing that you have to know is that the left and right is based on the left and right of the maternal pelvis. It is not your left and right. Is this clear? Yes. So when you say actually it's a left blade or it's a right blade, you have to know that it is, if you say it's a left blade, or it has to go onto the left maternal side. If you say it is the right blade, it has to go on the right maternal side. So you have to know why you call it left and right. Theek? Now, let us try and understand how to hold it and how to identify left and right. Okay. Now, I think I will need a black background for this. So let me put a black background so that I'm able to show it. Yes, so that's what I was saying. You're going to hold the instrument correctly. Now, what is correct? Okay. You have to hold them, number one, facing, अच्छा पहले एक को सिखाती हूँ फिर दूसरे को सिखाऊंगी. How do you hold the instrument? The instrument has to be held in such a way that, I repeat, the concavity is anterior. Yes? Can you all see this? The concavity has to be anterior. Convexity has to be posterior. The toe has to be facing up. It cannot be facing down. This is incorrect. This is totally incorrect. Convexity anterior आ गई, concavity posterior आ गई, toe नीचे आ गया. गलत. Correct क्या है? concavity has to be anterior, convexity has to be posterior, the toe has to be upwards. Is this clear? Yes, itna clear hai? Now, the same thing I will do with the other. So this is the other one. Okay. So if I'm holding the other one, again, let's look at this. Concavity anterior, convexity posterior, toe up. Not this. This is wrong. ऐसे पकड़ूंगी तो क्या होगा? Convexity anterior हो गया, concavity posterior हो गया, toe down हो गया. गलत है. Right? So I have to hold it how? How? Look at this. Concavity anterior, convexity posterior, toe up. Now when I hold it like this, there will be only one way where you will be able to hold it. If you can see this, एक ही तरीका है जिससे इसको आप पकड़ सकते हो, like this. Can you all appreciate? Now when you hold it correctly, when all three things are met, मेरी बात ध्यान से सुनना, and I hope सबको हिंदी समझ में आती है. जब आपने इंडिविजुअली करेक्ट पकड़ा होगा तो एक ब्लेड होगा जिसमें सॉकेट अपवर्ड्स आ रहा है. कैन यू सी दिस? द सॉकेट इज अप. यस, दिस अप इज एक्चुअली गोइंग टू बी द लेफ्ट ब्लेड. ओके, जिसमें सॉकेट ऊपर आ रहा है. दिस विल गो इन टू योर लेफ्ट हैंड. लुक एट दिस, आई एम होल्डिंग इट इन माई लेफ्ट हैंड. ओके, आई विल जूम आउट एज वेल. So I am holding it in my left hand. Can you all see toe up? Yes, toe up, concavity anterior, convexity posterior. And now do you see कि इसमें socket ऊपर आ रहा है? Can you all appreciate the socket? थोड़ा सा zoom करते हैं. Can you appreciate the socket now? Yes. Now I'll see the other one. Look at the other one. In the other one, when I hold it correctly, okay, I'm going to show it to you, zooming in. When I hold it correctly, which is toe up, concavity anterior, convexity posterior, do you see इसका socket नीचे आ गया? Yes. Can you all appreciate this? इसमें अब socket नीचे आ गया. जिसमें socket नीचे आ रहा है, that goes in my right hand. Okay? That goes in my right hand. और जिसमें socket ऊपर आ रहा है, that goes in my left hand. Can you appreciate now? Socket नीचे is my right hand. I am moving it right now. जिसमें socket ऊपर आ रहा है, that is in my left hand. Yes. So this is the one in my left hand, which is this, जिसमें socket ऊपर है. Can you all appreciate? Socket ऊपर है. I am going to hold it in my left hand, and this is going to go into the left maternal side. Okay. It will go to the left maternal side. Whereas the right one जिसमें socket नीचे आ रहा है, yes, you can see the socket now, will go onto the right maternal side. It will go into the right maternal side. Now I will tell you the reason why this is important. The reason this is important is the left blade has to go first. Only then will you be able to lock them. Right? So only correctly अगर आप डालोगे, only then will you be able to lock it. So I repeat, the one जिसमें socket ऊपर आ रहा है, जब आप तीन चीजों का ध्यान रखोगे, socket automatically ऊपर आएगा. This has to go first. On top of this, look at this. On top of this, I've put the other one, and then I am locking. Yes, could you see this? So I have introduced the left blade first, because only then it can be locked. Can you all appreciate? I will show it to you once again. So I said, holding it correctly, the left blade will have socket up, as you can see. Right? That's the socket. On top of it, I am keeping the right blade. And then I have to simply slide it in. Yes? So now will you be all able to identify the left and the right blades? Yes? So everybody was asking me, ma'am, left kaun sa hai, right kaun sa hai? So is this clear now? How did we do this? Yes? So quickly give me a thumbs up, and then only I will go further, because then I have to teach you ye sab kyun zaruri hai. So quickly, is it clear to everyone? Yes, bacha? Okay. So, simple steps that I said that you have to follow. You follow the 3 rules. What are the rules? The toe should be pointing up always. Concavity has to be anterior. Convexity has to be posterior. Yes? Yes? Is it clear? Is it clear to everyone? Yes, anterior posterior is again with respect to the maternal pelvis. जो sacrum में side जाएगी वो posterior है ना, और concavity जो है वो anterior रहेगी when you hold it. Okay? No, left goes to the maternal left side. That's why it is called as the left blade. Okay? It is in your left hand, but it goes onto the maternal left side. ठीक? Please understand उसको left blade कहते क्यों हैं? Left blade कहते हैं because it has to go onto the left maternal side, बच्चा. Yes, is it clear? Is this clear? उसका नाम ही ये है, right? Okay. Now coming to the question. जब आप पकड़ लोगे, correctly lock करके दिखा दोगे, right? The examiner will ask you, why is it important to know the left and the right? Why is it important? I told you. The left blade has to be introduced first. When you answer this, the examiner will ask you why. Why should I introduce the left first? Why not the right first? Only when you introduce the left blade first, will you be able to articulate, because the left blade has to be lower. I am repeating. The left blade has to be lower, the right has to be on top of it. Then it has to be slided onto each other. अगर आप उल्टा कर दोगे, right पहले डालोगे, the right blade becomes lower and then on top of left. ये lock ही नहीं होगा. Right? Is this clear? So, if your examiner asks, this is left, this is right, why do you want to know left and right? Your answer has to be, Madam or sir, because the left blade has to be introduced first. Then they will ask you why? Why should I introduce the left blade first? The reason is the left blade has to be lower down. Only then can you articulate it in the maternal pelvis. Right? So that is why, you know, when you were undergraduates, we used to teach you, okay, we used to teach you that, that, you know, you first articulate them. So we used to teach you that you first articulate them, and only when you articulate them would you actually know which is left and right. Right? So left blade has to be introduced first, the right has to be introduced later. So always articulate it and then disarticulate. And then you will know that the one in your left hand is the left blade. It has to go first because it has to be lower down. The right has to be on top of it, and then you're going to slide. Okay, is it clear? No, Priyank, it is vice versa. Okay? Right. Then this is how you're going to introduce as well. So सबसे पहले क्या करते हैं? Now when you have to introduce the blade, okay, just a moment. Yes. So coming back. Now once you know what is left and right and which is to be introduced first, to introduce blade you have to keep certain things in mind. Okay. सबसे पहले you will take the left blade, the one which has socket upwards, and you will hold it vertically in front of the introitus. So number one, you will hold the left blade vertically in front of introitus. Okay, right? And how do you hold it? By your left hand, and you're holding it in a pen holding manner, right? Look at me, right? So we're going to hold it in a pen holding manner. Yes, so vertically in a pen holding manner in front of the introitus, right? And you know, we have to keep it almost parallel to the inguinal ligament, right? So keep it almost parallel to the inguinal ligament. Now, you are going to use, so this is in your left hand, the blade. What are you going to do with the right hand? You know, 4 fingers of the right hand. Sana, it is absolutely fine. Can you exit the window once and come back? Maybe it's your local connection, beta. So now what do? 4 fingers of your right hand. They are in a semi-supinated position. Okay. So you will keep them in a semi-supinated position. Are introduced between where and where? Between the fetal head, okay, and the left pelvic wall. Please remember, it is just the 4 fingers. So 4 fingers in a semi-supinated position are introduced between the head of the baby and the left pelvic wall. The thumb has to be outside. Okay, so ये डालूंगी, but the thumb has to be outside. Thumb भी अंदर नहीं जा रहा है. Okay, the thumb has to be outside. Now, along this, my left blade is going to go. So along this, my hand, the left blade is going to be introduced, right? Now, where is the thumb going to be? So listen to me very carefully. The thumb is going to be kept on the convex side. I'll again bring the black border as well, right? Let's look at this. So fingers यहाँ हैं along, और thumb कहाँ है? Let's see. Thumb is along the convex border. So it's like guiding the forceps, right? So thumb is on the left border and the fingers are inside. Yes, is it clear? Then yes, so that is how, so you will introduce the left blade right. So introduce the left blade along the fingers. Okay, and as I told you, the thumb is going to gently give the direction. Yes, so with the thumb, you're trying to push with a passive movement. With passive movement of the thumb. Right, so I told you that the thumb is going to be on the convex border. It goes in easily. The same thing has to be reversed on the right side. So उसमें हम क्या करेंगे? The right blade will be held vertical in front of the perineum, right? But now the fingers of the left hand will go, and then the thumb on the convex border, and it will gently direct it towards the right maternal side, right? Is it clear? As I told you, only if you have introduced it correctly, you will be able to lock. So then you will lock the blade. So if you have introduced it correctly, you will be easily be able to lock the blade. There will be no problem at all, right? Now, when you are applying these forceps, how would they actually look on the baby's head? This is how they will look on the baby's head, right? So please look at this. This is how they will look on the baby's head once you have locked it, right? So please remember that the blades are applied along which diameter? the blades are applied along occipitomental diameter, which measures around 12.5 to 13 centimeters, right? So 12.5 to 13 centimeters is the occipitomental diameter. Yes, Priyank, you will say, you can say the heel, but heel में ना concave part भी आता है और convex part भी आता है. So when you say heel, आप specify नहीं कर रहे हो कि आपने concave side पे रखा है या convex side पे रखा है. So we have to ensure that we are specifying that the thumb has to be kept on the convex side of the blade. Okay? Is this clear? Right. So please remember, as you can see, the toe is along the cheek of the baby. Yes, the toe is along the cheek of the baby. Yes, is this part clear to everyone? Now comes the next basic things, which again I feel most of the people don't know. Before I go to the next thing, quickly telling you about the classification of forceps, right? Then I will tell you what should be the direction of pull, right, in different types of forceps. So to know the direction of pull, we will first have to know the classification as well. So as I said, these days we almost always use either a outlet forceps or a lower forceps. So when you say it is an outlet forceps, what do we mean? We mean the scalp should be visible at introitus, okay, so scalp should be visible at the introitus, head should be on the perineum, and skull on pelvic floor. Okay, so scalp should be visible at introitus, head on the perineum, and skull on the pelvic floor. All right. Now, second important thing, the sagittal suture. Okay. I will show it to you again, PG Gynae. Okay, the sagittal suture should be in the epidiameter or in right or left oblique diameter, right? So just sagittal suture of the baby's head preferably should be in the antero-posterior diameter, but it can also be either in the right oblique or in the left oblique diameter. Is it clear? Yes. The third thing, rotation of head should be less than 45 degrees, which means in case the sagittal suture is not in AP diameter, it is short of AP diameter, and then the rotation should be less than 45, right? So these are the things that you should know will qualify it as an outlet forceps. Is this clear? Is outlet forceps clear? I will tell you about the thumb again, okay, don't worry. But is outlet forceps clear to everyone? Right? Next, we talk about low forceps. You call it as low forceps if the station of head is more than or equal to +2, but it is not on the perineum. Because if it is on the perineum, then it is outlet. So when it is more than or equal to +2, but it is not on the perineum, that's when you say it is low forceps. The forceps we use is going to be the same that you use for outlet. So Simpson's, Tucker McLean, Elliott or Wrigley's, they are all outlet forceps, but they will also be used for low forceps. So the instrument that we use is same whether you talk about outlet or you talk about low. Okay? What is mid cavity? Shelly, I will just answer your question, beta. Okay, just a moment. Mid cavity कब कहते हैं? If the station is between 0 and +2, right? So if it is between 0 and +2, it is called as mid cavity. Modern obstetrics में mid cavity forceps अब use नहीं हो रही है, right? So in modern obstetrics, we are not using the mid cavity forceps. And on that note, I actually have something interesting to tell, that I am a mid forceps delivery child. I was born as mid forceps delivery, right? So yes, in those times, they used to do mid forceps deliveries, but today in modern obstetrics, we are not doing mid cavity forceps, okay? So we are either doing outlet or we are doing low. Is it clear? Right? पहले एक और क्लासिफिकेशन में आता था हाई फॉसेप्स. ओके, सो हाई इज व्हेन स्टेशन इज अबव 0. सो ये तो अब बिल्कुल ही बना हो गया है, बिकॉज आई सेड द मिनिमम रिक्वायरमेंट नाउ डेज इज दैट हेड शुड बी एटलीस्ट एंगेज्ड, राइट? सो अब हाई का तो बिल्कुल सवाल नहीं होता, बिकॉज दैट मीन्स द हेड इज नॉट एंगेज्ड. So there used to be this in the classification as well, but these days even mid cavity, although it is in the classification, we are not really doing mid cavity forceps. Yes, is this clear to everyone? Okay. Now coming to correct application again, and some of the doubts that you students have asked. So first thing you will understand when I show you a picture. Okay, I think Shelly has asked, ma'am, how to check for rotation. So बेटा उसी के लिए तो आपको sagittal suture देखना पड़ेगा, और in other words you will have to see the location of the anterior and posterior fontanel. Yes, so look at the position of the occiput, right? Look at the position of the anterior posterior fontanels to actually know whether there is a rotation or not. For example, in this particular picture, if you see, yes, the sagittal suture is in the AP diameter. Yes, can you see this? That sagittal suture is in the AP diameter. Can you all see this? Right, so when this is in the AP diameter, it means there is no rotation, right? So it is without any rotation. If this is the AP diameter, and if sagittal suture is going to be like this, that means there is a rotation. So for this, you will have to look at the fontanel's cup position, okay? And that's what I said. If there is rotation, but if the rotation is less than 45, then you can still use forceps, okay? So if it is less than 45, you can still use forceps. Yes, is it clear? Right, now, correct application, एक हमने बोला कि that if we have correctly applied, we'll be able to lock, as you can see here. But what is even more important as postgraduates that you should answer if they ask you about correct application is that correct application is to know, is what you are supposed to answer is that the blades have to be equidistant from the sagittal suture, right? So the blades should be equidistant from sagittal suture, and that is what is correct application. Is this clear? So also somebody else's doubt was the thumb. So see, the forceps I am holding in my left hand, the right hand was inside. It has to go along the hand. Look at the thumb. The thumb is going to be along the convex part, because that is how I'm going to introduce. So I'm holding the wrong thing, right? So look at this. Can you appreciate now? My thumb of the right hand. So the blade is going along the fingers. The thumb is along the heel, but along the convex part of the heel, where you will give it gentle push so that you can slide it in. देख पा रहे हो मुझे? I'm going to push it like this with my thumb. Can you all appreciate? I have to do a passive push. Yes? Is it clear? Okay. Then one of our students, Amigo, I don't know what his or her name is asking about Das forceps. So, you know, in India, we have introduced a lot of variations because Indian women are more petite, okay? We have, as compared to white women, right, we are more petite. So, we have various, types of forceps which are made for Indian babies as well. And Das's forceps is actually one of them. It was introduced by Kedarnath Das. Okay, so introduced by Kedarnath Das. As you can know from the name, he was from Calcutta, and this was typically taken out for Indian babies, right? So it's again a outlet forceps only, right? So Das forceps, right? So this is, how is it different from Wrigley's, if you ask me that? This is slightly longer than Wrigley's, right? And it is more lighter. So it is a little longer, it is a little lighter, right? And as I said, this was simply a adaptation for Indian babies and nothing more about it actually. Is it yes? Or right? So that's what you should know as far as Das forceps is concerned. Okay. Now, once we have done this, now coming to the traction, things that you should know about the direction of pull and how to pull, because that's another place where I feel that students really get confused. They don't know what they have to answer. So this is again going to be very basic, but I know that most people don't know it and most people will not teach you as well. Okay, so let's look at this. So first, consider the woman lying like this. The most important thing that I have to tell you is, जब भी आप direction of pull बोल रहे हो, it is not according to you. ठीक है? So direction of pull is not according to you. Direction of pull is according to the patient. Right? So इसीलिए मैंने आपके सामने एक supine position में patient को लेटाया है who is pregnant. So based on this woman, if you pull it in direction number 1, it is called as downwards. Yes? Based on the position of the woman, if we pull it in direction 2, you know, most of you students will call it as upwards. Yes, this is not upwards. This is still downwards. Okay, so this is downwards and forward with respect to her pelvis. Right, so with respect to her pelvis, you are pulling it down and forwards. Similarly, position number 3 will be only forwards. Yes, is it clear? Is it clear to everyone? So downwards is position number 1. It is with respect to the pregnant woman. Position number 2 is downwards, not upwards. Please usko upward mat kehna. That's the biggest mistakes that we people do as juniors. Okay, so position number 2 is downwards still and forwards with respect to her pelvis. Position number 3 is only forwards. Similarly, what is position number 4? Down and back. Back with respect to the pregnant woman, not according to you. Okay, and position number 5 is only backwards. Is it clear to everyone? Are these positions and terminologies clear? Because I don't want you to make mistakes. Is it clear? Now once you know this, you will understand this as well. So if I am using an outlet forceps, जहाँ पे head कहाँ पड़ा है? The head is going to be on the perineum. Yes? So the head is going to be on the perineum. What do you think should be my first direction of pull? जल्दी बताओ. So consider the curve of Caras. Curve of Caras कैसे होता है? It's C shape. आपको पता है? Curve of Caras. पहले पीछे जाता है, फिर आगे जाता है. Right? So पीछे मतलब backward, आगे मतलब forward. Right? So now the head is already here. Can you tell me the direction of pull? What would be the first direction of pull? It will be 1. The first direction is only downwards. So I pull it more out. And then I have to take it up. Right? So again, not up, it has to be forwards. So position 1 where I will pull, or the first pull will be only downwards. The second pull will be downwards and forwards. Yes, is this clear to everyone? So the first pull is only downwards. The second direction of pull will be down and forward. Is it clear, beta? So this is for outlet forceps. Yes, clear to everybody? Now let us look at if we are doing a low forceps delivery. So if we are doing a low forceps, abhi head perineum pe hi nahi aaya hai, right? So for the low forceps delivery, the first pull will be down and back. Right? So the first direction of pull will be downwards and backwards. Is this clear to everyone? Yes, these are very basic things, but unfortunately we are not being taught all this, right? The second will be what? The second will be only downwards. So पहले में आप उसको perineum तक लेके आए हो. So when you are pulling it down and back, you're first bringing it to the perineum. Once it is perineum, then you pull it only down, and finally you will pull it. Third direction of pull will be downwards and forwards. Right? Is the direction of pull clear to everyone? So with this, I've taught you the direction of pull of both the low forceps as well as outlet forceps. Yes, clear? Okay, two things that you should understand about the traction. So this is the direction of traction. Once you know the direction in which you have to pull, the other thing you have to know is that your traction has to be steady. Okay, the traction has to be steady, not rocky. मतलब jerky movements नहीं होना चाहिए, पहले ऐसे pull किया फिर ऐसे किया, no. It has to be steady traction. It should not be rocky traction. Okay, very, very important. Second, I have already told you the traction is along the axis of curve of Caras or the pelvic axis. Yes? And the third thing about the traction that you have to know is that it is synchronous to the contraction. Okay, that it is synchronous to the contraction. Yes, is it clear to everyone? Yes? Okay. Backward. Backward में क्या clear नहीं है बेटा? Backward आप पहले इसलिए ले जा रहे हो कि आपको उसको नीचे लेकर आना है. Right? It has not yet come to the perineum. Remember, it's a low forceps, which means the station is more than +2 but not reached the perineum. So the first is down and back. Please remember, back is with respect to the pregnant woman. So consider her uterus. Okay, consider the uterus. Uterus के हिसाब से forwards or backwards ध्यान रखो. Right? So if you are going behind the uterus, then it is backwards. Right? So only with these movements you're moving it actually along the curve of Caras. Right? So curve of Caras भी ऐसे ही जाता है, पहले backward जाता है, जब नीचे आ जाता है तो फिर forward जाना शुरू होता है. Right? So इसीलिए first to bring it down you have to take it down and back. Once you have brought it to the perineum, then you bring it even more out, right, by pulling it out, so downwards, and then you have to take it downwards and forwards. Okay? Low forceps, yes, I will repeat. So I said in the low forceps, the first direction of pull has to be down and back. So consider this with respect to the pregnant woman lying in front of you. Back because you are moving it away from the uterus. So when you move it away, it is backwards. Yes? So ये देखो ना, अगर ये pregnant uterus है, अभी मैंने दिखाया तुम्हें. If this is the pregnant uterus, this is backwards, this is forwards. Right? This will be downwards. Yes? So you first move it downwards and backwards. The second direction of pull will be only downwards. उसके बाद तो जो आपने outlet में किया है वही करना है, right? So second is only downwards, and the third will be downwards and forwards, right? Is it clear now? Ayushi, you asked me to repeat, beta. Is it clear now? Yes, absolutely right. Okay, so that's how it has to be. And then 3 other things I asked you to keep in mind when it comes to traction. Traction has to be steady or continuous, not jerky or rocky. Traction has to be synchronous to the contraction. So जब आप pull कर रहे हो, it has to be synchronous to a contraction. And as I said, the direction we have already talked about. It is along the curve of Caras, right? Now, up till what time can you try instrumental delivery? So what is the time limit? So time limit is that you're going to try for a maximum of 30 minutes, right? Which means what I am trying to tell you is you have to know when to abandon the procedure. Right? So when to abandon the procedure. So one is if you have not achieved delivery within 30 minutes. So at 30 minutes, if not delivered. Second, if there is no descent, right? So if descent does not easily proceed, right? So if you are feeling that despite your pull, the baby's head is not coming down. So if descent does not easily proceed, or if you're feeling that yes, there is a descent, but it's already been 30 minutes, then you should abandon. Also remember that you should abandon it if you feel that it is difficult to apply the forceps. Then probably you don't really know how to use the device, so better don't use it, right? So if you feel it is difficult to apply, right? So those were the special things that you should know about forceps delivery. Yes, so those were the special things that you should know about forceps delivery. We will talk about vacuum now, but if you want a short break, we can take that. And then we will just have a little comparison between forceps and vacuum, right? Should we take a little break? 5 minutes or 10 minutes? How much do you want? We'll take a short break and then we will start with vacuum and then we will do a comparison of the two as well. Yes, Devyani, that is for vacuum beta, not for forceps, because when you talk about number of pulls, those are with respect to vacuum. As I said, in forceps, it is going to be a steady traction. It's not jerky traction. So there are no pulls. So aap jo pooch rahe ho Devyani, maximum number of pulls, that will come when I talk about vacuum. It doesn't hold true for forceps. Okay? Okay, so we'll take a quick break and we will restart the class in 10 minutes because wo off karte karte or on karte karte 5 minutes ho jayenge, right? So we will restart the class at 7:05 p.m. Okay, so approximately 7-8 minutes, right? Chalo. So everyone back. All right. So I was going through the doubts that you have put in the chat box. Yes. So someone had asked about what is trial of forceps. Okay. Now, see, when you talk about trial of anything, it means you are unsure of presence of disproportion, right? So basically, trial of forceps is something that we do जैसे कि if you remember when we used to talk about a cephalopelvic disproportion, we used to say that we will do a trial of labor. So similarly here we use the words as trial of forceps. So this is basically done when there is doubtful mid-pelvic contraction. Right? So which means you're not very sure about the mid-pelvic space, especially the interstitial. So if it is doubtful, then you can do a trial of forceps delivery, but what you have to do is you have to keep everything ready for an emergency cesarean. Right, so you have to keep everything ready for a emergency cesarean section, right? So that's when you say you're doing a trial of forceps. So what will happen is, if with moderate traction you are able to pull down the head, then you will continue the process, right? So if with moderate traction you are able to pull down the head, then you continue, right? So then you keep pulling. But if you feel that no, you're not able to bring down any descent, then you will take her up for a cesarean section, right? So this is what is called as trial of forceps, right? When there is suspected contraction, you're not sure, right? So there is a disproportion and it is suspicious, then you can give it. But again, this is something we don't do in modern obstetrics. Whenever you feel that there is a cephalopelvic disproportion, please do not do instrumental delivery. That is what you have to remember. Agar aap jate saar, if you tell the examiner that you are suspecting CPD and you will put a forceps, then you know this is a grossly incorrect answer, right? So as far as modern obstetrics is concerned, once we feel that there is cephalopelvic disproportion at any level, we will not do instrumental delivery, okay? Failed forceps. Beta, abhi to aapko bataya failed forceps kya hai, right? So agar, see, this is what I have written. When I say abandon the procedure, this is what I mean by failed forceps, which means difficult to apply. So it could be, you may have complete failure of application, you may have failure of locking, right? So if you are unable to lock or if you are unable to apply, then right, then you have to abandon because it is a failed forceps. Then as I said, you are not able to deliver the head within 30 minutes, then again it is a failed forceps. If you feel that it is not easily causing descent of the head, then it is again called as a failed forceps, right? Absolutely not, Priyank. I will talk about sequential things, but it's a big no. So what Priyank is asking me, is asking about sequential use, you know, which means if you have used one instrument and that fails, should you use another instrument? The answer is a big no, okay? Because you will cause maximum injuries to the fetus and to the mother, actually more to the fetus, if you use sequential instruments. So you have to follow this principle. This is what you have to answer in the exams as well. If one instrument fails, then we are going to take the patient up for a cesarean section. Do not try sequential instruments. Very rarely, you know, we try sequential instruments. When we do that, कि भाई किसी first year ने लगाया instrument और उसको लगाना नहीं आता था, and that's why it failed. Then yes, a senior can come and try other instrument, but otherwise a big no. For your exams, you have to say no sequential instrument use. Okay, is this clear? Right. Now, since you've asked me, you know, they're the same questions which you are asking. We've already covered that. For example, if I ask you, what do you think are the causes of failed forceps? I'm sure you will be able to tell me. Can you tell me what would be the reason that your forceps will fail? So one of the most important thing is that maybe there was malpresentation. So you did not do a good check of prerequisites. So if you haven't checked for malpresentations, if you haven't checked for cephalopelvic disproportion, right? If you haven't looked for occipito-posterior, very, very important. A lot of times it is actually occipito-posterior position which remains undiagnosed, and then you are trying forceps and it is going to fail, right? Then, as I said, if there is obstruction in the way, for example, a fibroid or an ovarian tumor, right? So any soft tissue obstruction, right? So any soft tissue obstruction, this could also cause a failure. Then if there is a presence of a constriction ring, right, which is because of incoordinate uterine contractions. So if there are incoordinate contractions, a constriction ring may form, and this constriction ring may lead to a failed forceps delivery. Yes, so these are the things that you should know when it comes to what is failed and what could be the probable causes of failed. Among these, please remember the most common cause will remain as an undiagnosed occipital posterior position. Yes. प्रियांक, जो भी सारी तुम चीजें बोल रहे हो वो बहुत ही पुराने जमाने की हैं. So we are no longer doing any kind of manual rotations. The head keeps slipping. Actually, if you try and grasp it manually, it slips. Sometimes it even goes above the brim also. Right, so manual rotation is something that we are not doing in modern obstetrics. Again, in fact, we are not even using Kiellands. Right, so we rarely use Kiellands to bring about rotation. Or manual is a big no, because most people do not know how to do manual rotations. For you people, practically as well as clinically, you're soon going to become consultants, professors, practicing clinicians. Yes, if there is a deep transverse arrest, which most of the times is because of an abnormal shape of the pelvis, like an android pelvis, please no manual rotations, no Kielland forceps, no forceps. Right? So if it's a DTA, you should be taking the patient up for a cesarean section. Right? Okay, Priyank, I hope that solves your doubts. And, it is nice that you ask doubts, because that makes it more interactive and that helps us. Okay. No, so Priyank, if the sagittal suture is not in AP diameter, you don't have to do the rotation. See, as a part of normal labor itself, when the head descends, it undergoes rotation. Yaad hai na, Priyank? We talk about internal rotation. So it will spontaneously rotate, and along with that rotation, your hands have to generally move. You will never twist the forceps. That's also something that you have to remember. You don't have to manually turn the outlet forceps. You will cause major injuries, right? So apne aap hi head rotate hota hai. I'm sure you remember the internal rotation. And when the head is moving automatically, the forceps have to just follow that movement passively. No active turning or twisting of the forceps. Okay, Priyank? Okay. Then let's talk a few things that you should know about vacuum. Now, most of the things that we have talked as prerequisites remain the same. So please remember, indications, okay, contraindications, prerequisites remain the same, right? So I'm not going to repeat that. Those are the same. Remember that when it comes to vacuum, a few more things that I would like you to know, because they were not true for forceps, but they're true for vacuum. Please remember, if the POG is less than 34 weeks, a vacuum is absolutely contraindicated. Okay? So, if the gestational age is less than 34, vacuum is absolutely contraindicated. Then, if the baby has prior scalp sampling, although we don't do scalp sampling in India, but yes, as a theoretical answer, so prior scalp sampling, right, or scalp electrodes are relative contraindications to vacuum application, right? So they are relative contraindications to vacuum, right? Now, when it comes to vacuum device, let's look at a few things and then I will tell you what you need to know. Okay, so this is the vacuum cup. Okay, so these are the vacuum cups. So as you can see these days in modern obstetrics, we are using plastic cups. Okay, they are made of a material which is called as silastic. Okay, so the material is silastic. We are not using metallic cups now because they cause more trauma to the baby. So metallic cups are rarely used. Okay. Then when we talk about these plastic cups, they are obviously, most of them tend to be soft cups. Okay. They are soft cups. They come in two shapes, as you can see here. So if I label them as 1 and 2, so 1 is mushroom shape, right, and 2 is bell shaped. So more commonly, which one is used? Can you tell me? So more commonly we are using a bell shaped vacuum cup, right? But what is the disadvantage of bell shaped cups? They are more likely to get detached. Right? So they are more likely to get detached. Is it clear to everybody? Yes? Right. Then diameter. So it could be again variable, but generally the cups are having a diameter of 5 to 7 centimeters. Yes, so generally they have a diameter of 5 to 7 centimeters. Now, over a period of time, different types of devices have come. For example, ये पुराना device है. As you can see, cups are separate with the tubing, and the pressure device is separate. Yes, can you see that? This is the one which is manually operable. There are such separate devices which are operable by foot as well. For example, in our hospital, it used to be a foot operated pressure device, right? So this is one variety where the cups would be separate and the pressure device would be separate. But nowadays we have a single device as well. For example, this is a device which has an inbuilt pressure system as well. So cup or pressure एक ही device में आता है. This is called as MITI-1, right? So it's a one-piece vacuum device. Similarly, there is a Kiwi cup as well. Okay, this is also a single device. So pressure and cup together in one, right? So it is a single device. So nowadays we are having these different types of devices. So कोई फर्क नहीं है, it's just the advancement that they've converted two things into a one common device. Okay, then once we know about this, a very important thing that we have to know is, just give me a moment, okay, is okay, just a moment, I'm just trying to open something to show it to you. Okay. Okay, please give me a moment so that I can show it to you. Just trying to see where my okay, just hold on, I just have too many just a moment. I'm looking for one particular image that I have to show you, which I am unable to find out. Okay, just give me just 2 minutes, okay? I'm just going to be back. Okay, I'm so sorry. It took me a little time, but finally I've got the image. Okay, are you all able to see this image? I'm so sorry for the delay, bachas. So sorry. Right, but this image was important so that I can tell you what I am trying to show you. So, are you all with me now? Okay, right. So let's look at this. So this is the vacuum cup, okay, that we have placed. Now the first and the most important thing about the vacuum cup is exactly where you're going to place it, and that's why I took a little time to find this image for you. Now please remember that there is a sagittal suture on the baby's head. Yes? Now the vacuum cup, where you have to place it is very important. Okay, so on the sagittal suture of the baby's head, right, so on the sagittal suture of the baby's head, there is a point which is called as flexion point. Yes, so there is a point which is called as the flexion point. Now if you look at this flexion point, where is it placed? So it is 3 centimeters anterior to which fontanel? 3 centimeters anterior to posterior fontanel. Yes, can you all appreciate that? And how do you identify the posterior fontanel? The posterior fontanel is triangular. Yes. If you look from the anterior fontanel, which is rhomboid in shape or diamond shaped, the flexion point is 6 centimeters posterior. So it is 6 centimeters posterior to anterior fontanel, 3 centimeters anterior to the posterior fontanel. Okay, is this clear? Now the flexion point is the point where the center of the cup has to be placed. Is it clear? So the center of the cup, okay, center of the cup has to be placed on flexion point. Can you tell me the reason why? Can you tell me the reason why? The reason is because, as the name suggests, it is a flexion point. So when you apply the cup at this point and then you will pull, it will ensure that the head goes into flexion and smaller diameters are delivered, right? So the center of the cup always has to be on the flexion point. Now you are going to tell me something. How will we ensure that we are placing it on the flexion point? Do you think we are going to have a ruler or a scale in the labor room, and on the baby's head we will do these measurements and then place the cup? Do you think we are going to do that? So please remember, no measurements. So this is where the experience and expertise of clinicians come in. So you have to try and place the cup close to the posterior fontanel. So what we do is that with our experience, we will place the cup, and then after placing the cup, you will check. Now comes the question, how will you check for correct application? Let me see if anybody can answer this question. How will you check for correct application? Batao, kaun answer karega? So in order to check for correct application, you have to look at what? Perimeter of the cup. So after placing, you will put your finger all along the perimeter of the cup. The perimeter of the cup, bache, has to touch the posterior fontanel. Are you all able to appreciate that? That the perimeter of the cup is going to touch the posterior fontanel. So if the perimeter is touching the posterior fontanel, that means that this is correct application. Yes, is it clear? Very important. Vacuum में और कोई training नहीं चाहिए. This is the only thing actually that you have to know about the vacuum is correct placement, right? So very good. Yes, amigo. So the cup perimeter has to touch the posterior fontanelle. Please understand that the cup does not cover the fontanelle. Okay? So cup will not cover the fontanelle. Okay? But rather the cup perimeter should touch posterior fontanelle. Is this clear? This is what we want you to know, right? Now, pressure. How much of pressure is to be generated? Don't worry, Sana, you haven't, I'm sure you'll be able to cover up better. Okay, so how much is the pressure? So we say 0.8 kgs per centimeter square. Yes, so 0.8 kgs per centimeter square, or we say 600 millimeters of mercury, right? Or we say 600 millimeters of mercury. Is that clear? Now, as I was telling you that things have changed from previous times. So if we ask you, should it be rapid application of pressure or slow application of pressure? What is going to be the answer? So these days we don't do gradual increase in pressure. Earlier we used to say it like this. We will increase 0.2 kg every 2 minutes. ये पुराना है. Okay, so 0.2 होगा. फिर after 2 minutes we'll make it 0.4. Another 2 minutes we'll make it 0.6. Another 2 minutes we'll take it 0.8. So this is older concept. Nowadays with soft cups, we are able to rapidly apply the suction pressure. So rapid application of suction is what is done now. Okay, so rapid application of suction over 1 to 2 minutes. That's it. So over 1 to 2 minutes, you will raise the pressure to 600 millimeters of mercury, right? If someone asks you what is the total traction force, okay? So again, total traction force yes, these are the things that we really want you to know, okay? So total traction force that you are going to apply comes out to be about 17.6 kgs. If they ask you specially for multi-paras women, the multi-paras women will need less traction. It is around 12 kgs. So the general answer is around 17.6 kgs. That is the total traction needed. But for multi-paras women, it can be 12 kgs as well. Now, some of the things that you have to know, which are core clinical things. Okay, for example, your pull has to be synchronous to a contraction. You will not pull unless there is a contraction. So when the uterine contraction comes, that's when you're going to start pulling. That's the first thing. Now, second thing which people don't understand. One maternal push. So at the time when mother is pushing, whatever set of pulls you apply, you may pull it 1, twice or thrice. We call it as one set of pulls. So एक maternal push के साथ जो आप pull कर रहे हो, it may be 2 times, but it is still considered one set. Am I making myself clear? Yes? Am I making myself clear? Right? So the set of pulls that you do with one maternal push. So ventouse या vacuum के साथ maternal pushing is required. Okay? Pushing is not required with forceps. For forceps, you only need a contraction. With vacuum, the mother has to push as well. So when she is pushing, at that time you have to pull. Okay? And these are going to be synchronous to the contraction. So when you are pulling with the maternal push, it is called as one set of pulls. Why is it important? I will tell you. Okay? The stem of the cup, okay, the stem is kept perpendicular to the cup. Okay? The stem has to be kept perpendicular to the cup. Again the same things, don't twist the handle. Right? So whatever turning will happen automatically. Your hand has to simply follow the rotation of the head. So you will not twist by yourself. You will passively follow as the head rotates spontaneously, right? Now please understand the next thing. Traction has to be discontinued as contraction ends. Okay, so when the contraction is ending, you have to stop pulling and you have to ask the mother not to push. Okay, so when the contraction is ending, you have to stop pulling and you have to stop the mother to push as well. Now this is the difference that I want you to understand. Traction बंद किया है, मतलब pulling बंद किया है, pressure का क्या करना है? Who is going to tell me? Now when you're not pulling, what do you do to the pressure? Do you reduce it to zero? The answer is no. Okay. What you can do that is that in between contractions, okay, in between contractions, okay, what do you have to know? That you will reduce the suction pressure. So you can either reduce the suction pressure PG gynae, no. 12 kgs to multiparas के लिए ही चाहिए, right? So I don't know where the value of 10 comes from. For multiparas women itself, you will need 12 kgs. For primigravidas, you actually may need more, right? So what we say is that 17.6 is the standard older value. The newer value that has come up is 12 kgs, but actually that is more true for multiparas women, okay? Now, in between contractions, you can reduce the suction pressure to less than 200 or, so please remember that it's an or it can be fully maintained, right? So it can be fully maintained as well. There is no need to reduce the pressure to zero. You just have to stop pulling. Don't pull, don't reduce the pressure to zero. You can either maintain the pressure or you can slightly reduce it to less than 200 millimeters of mercury. Is this clear? Now, what is the maximum pulse? Now, this is what people don't understand. It is a maximum of 3 sets of pulls. Do you understand what I'm trying to say? So, one set क्या था? One set था जो एक बारी आप maternal push के साथ कर रहे हो सकता है उसमें आपने 2 बार खींचा हो, but it is still called as one set. So what is maximum is 3 set of pulls. If you are not able to deliver the baby by 3 set of pulls, then it is a failed vacuum. Yes? So please remember this. So when it comes to failed vacuum, what is it? So failed vacuum is no descent even after, right? So no descent even after 3 set of pulls, right? Or 3 cup detachments, which are also called as pop-offs. So 3 cup pop-offs, क्या मतलब होता है? For example, let's say the woman is getting a contraction, you've applied the cup, you've raised the pressure, you are waiting for the contraction. Now the contraction comes, she's going to push and you're going to start pulling. When you pull on the cup and the cup detaches, that's what is called as a detachment or a pop-off. So if 3 such cup pop-offs happen, or if 3 times the cup detaches, that is also considered as a failed vacuum. Is this clear to everyone? Yes? So that is also called as failed vacuum. Is this clear, bacha? Yes? Is it clear to everyone? Okay. Now, certain things that you should know when it comes to, if we have to know the complications with instrumental delivery, that's where we also compare forceps and vacuum. So if we have to talk about complications of forceps, okay, Okay, I'll keep seeing your doubts side by side. I have to use my phone for that. Yes, obviously. Beta, aapne cup laga ke, you have to wait, Vishakha. You have to wait for the contraction to come. When the contraction comes, the mother pushes and you pull. When the contraction goes away, you stop pulling. You have to wait for the second contraction to come. Okay? Yes, Vishakha, is that clear, beta? Alright. So in general, when I talk about complications, I know that you all know that a general answer is that forceps causes more of maternal complications. Right? Especially when I talk about maternal complications with forceps, these are in the form of lower genital tract lacerations. Right, so lower genital tract lacerations. It could also be vulvar and vaginal hematomas. Again, the time limit is same. Okay, so Priyank is asking me about the time limit. The maximum time limit for instrumental delivery remains as 30 minutes. Usually we take it around 15 to 20 minutes, but the maximum time that you can allow for trying with the instrument is going to be 30 minutes. If you are unable to achieve a delivery within 30 minutes, it has to be a cesarean section after that. Yes? Kajal, any time, if there are 3 cup pop-offs, it is a failed vacuum. It basically means you don't know how to apply it. So this is a common I would say definition for failed vacuum. 3 cup pop-offs. Number is 3. So once, twice, thrice. If 3 times it detaches while pulling, it's a failed vacuum. Okay? Right. So it could be vulval and vaginal hematomas. It could also be urinary tract injuries. And you all very well know it can also be anal sphincter injuries. Now something that I want you to know as far as maternal injuries and forceps is concerned, that maternal injuries are more severe. Okay, maternal injuries are more severe when forceps is applied in occipito-posterior position. Right, so therefore in OP, the injuries that you will cause to the maternal genital tract are going to be much more severe. You're more likely to cause 3rd and 4th degree perineal tears if you put it in OP as compared to OA. Yes, is it clear to everyone? Now, the major problems comes about fetal injuries. Now, a general rule that we say is that fetal injuries in general are more with vacuum as compared to forceps. But this is a general answer. There are certain fetal injuries which are actually more with forceps, and that's what the examiners are more likely to ask as well. For example, please remember this. If you talk about incidence of cerebral hemorrhage, intracranial hemorrhage, subarachnoid hemorrhage, right? These are more with forceps as compared to vacuum. Okay. Similarly, facial nerve palsy, brachial plexus injuries, and convulsions are again more with forceps as compared to vacuum. Okay. So facial nerve palsy, brachial plexus injuries, convulsions, right, these are more with forceps as compared to vacuum. Okay. On the other hand, if you talk about fetal scalp lacerations, and that's exactly what we said when I talked about HIV positive women. So fetal scalp lacerations, cephal hematoma, retinal hemorrhage, and shoulder dystocia. These are more common with vacuum as compared to forceps. So scalp lacerations, cephal hematoma, retinal hemorrhage and shoulder dystocias are more with vacuum. Then if we ask you about external ocular trauma, okay, so I'm not talking about retina here, I'm talking about external eye, right? So external ocular trauma and depressed skull fractures, they are again more common with forceps, right? So depressed skull fractures and external ocular trauma is again more common with what? With forceps as compared to vacuum, right? So, you know, you will always be asked about this comparison, and this is what you should know as far as maternal trauma and fetal trauma is concerned. What about neurodevelopment delay? So does instrumental delivery affect the neurodevelopment of a child? Tell me. Does it affect the neurodevelopment of the child? The answer is no. I am a living example. I hope you don't consider me retarded. So no, it doesn't. I told you I was a mid-forceps delivery, right? So no, the development or neurodevelopment of the child is not affected with instrumental delivery, right? So that's again something that you need to know, right? So these are the things that you should know about forceps and vacuum. If you have any doubts, do let me know. I will not be doing fetal skull today because we want to do the skull and the pelvis together, right? So we will do fetal skull, maternal pelvis together along with the mechanism of normal labor. We'll keep it in one of the days, right? But as of now, if you want to ask me any doubts, please go ahead. But I think you will not be asked anything beyond what I have taught you as far as forceps and vacuum is concerned. If you do want to know something, you can ask now, you can ask on the group as well. The next class we will keep day after tomorrow, and I would start with contraception, okay, and I think I will take it in certain parts. So I will cover one part definitely day after tomorrow. Okay, so 5 p.m. is alternate day okay with everyone? Yes, is alternate day okay with everyone? Yes? Okay, right. If any other doubts or otherwise we'll call it a day, and you know, we will meet day after tomorrow. Okay, if you don't have a doubt, I will ask a doubt. What is Chignon? What is Chignon? Anyone? So come on, tell me, what is a Chignon? Anyone? I'm waiting for your answers. Failure. So it actually depends if you have chosen your patient correctly or not. But as a general answer, Priyank, failure is more with vacuum. That is why we said if you are anticipating a difficult delivery, please select forceps. Because if you are anticipating difficult delivery and you use a vacuum, it will fail for sure, right? So vacuums should only be used when you are anticipating an easy delivery, right? So a general answer is failure is more with vacuum, but it is easier to apply and needs no training, okay? Very good. That's right. Dr. Ankita is right. It is an artificial caput succedaneum. So one caput forms in, cephalopelvic disproportion. So this is an artificial caput succedaneum, right? And this is produced during your vacuum application. So जहाँ आपने cup लगाया होता है वहाँ पे होता है, and it will spontaneously disappear, right? So you don't have to do anything. It will spontaneously disappear within 48 hours. Right? Okay. So I think you are all, Sana, vacuum would be, the recordings will be available soon after, most probably by midnight, the recording would be available. Okay, so we say goodbye, and I hope you find the class useful, right? I'll be happy to hear your feedbacks as well. Okay, so we meet day after tomorrow. So today is what day? Tuesday, right? So we meet on Thursday, 5 p.m. and we would start with contraception, because I think these were the topics that students wanted me to cover first. So the first request came for instrumental delivery, so I took up instrumental delivery. Then the request came up for contraception, so I will next start with contraception. We will do it day after tomorrow, okay, at 5 p.m. Vishakha, you can use instrumental delivery in IUDs, provided it's not a macerated baby. Okay, so if it is macerated, then the application of forceps or vacuum is going to be very difficult, because neither you can grip the bones get softened, and you can't generate a negative pressure. But if it is a fresh IUD, then yes, you can use instrumental delivery. It's not a contraindication. Okay? Is it clear, Vishakha? But if it's an old IUD, when you say old IUD, it means it undergoes maceration. Then you will not be able to apply the instrument because the skull bones get softened. Okay? Yes, all of you, please take care of yourself, take care of your family, take care of your patients. It's a tough time for everyone. I have been being pulled over by a lot of places, patients, family, phone calls. It's been pretty crazy, but I hope God is going to bring us out of this pandemic very soon. Please take good care of yourself, and let's pray to God to help us, because you know there are times when even doctors feel very helpless. I hope God doesn't put us in that situation, and let's hope for the best. Okay, so God bless you all. Take care. I'll see you day after tomorrow. Okay.